Good afternoon. Welcome to this symposium organized by PhysioAssist that will talk about Simeox Therapy, a new technology for physiotherapy in cystic fibrosis. My name is Laurent Morin, Medical Affairs Director of PhysioAssist, and I would like to introduce the three other speakers. Professor Dorota Sands, Head of the Cystic Fibrosis Department of the Institute of Mother and Child in Warsaw, and President of the Polish Science Society, who will present the main results of the homecare Simeox randomized controlled trial in pediatric CF patients. And from Germany, Dr. Dorit Fabricius and Dr. Hanna Schmidt, pulmonologists of the CF Center of the University Hospital in Ulm. They will present the results of a pioneering pilot study in adult CF patients. At the end, I will present a summary of expert opinions about 3 European virtual roundtables on Simeox therapy in CF care management that took place last May. As the session is short, we will not be able to answer to most of your questions during the session, but we will do later, please. And now, please, Professor Sands, you can take the floor.
Good morning. It's a big pleasure for me to be able to share experience of our center with this new airway clearance device and very first presentation of our results of the new study. There are my disclosures. Simeox new airway clearance device is already known in our center for our patients, but for those who are less familiar with the device, which is using combination of different mechanisms to eliminate respiratory secretion and mobilizing the mucus. Vibrating pneumatic signal during the patient exhalation is very helpful because it's much less effort compared to other methods and very effective mucus mobilization. We are more used in CF world to positive pressures. This time we work with negative pressure, but thanks to very short time of this negative pressure and series of negative pressure impulses during free exhalation, the airways do not collapse. And it's this device helping us to drainage distal airways, so difficult to achieve mucus mobilization from them. And it also gives possibility to personalize and really tailor therapy with selecting optimal set of parameters for the given patient. We already studied the device in our first study, which is published January 2021 in GMC journal, and that time it was applied to hospitalized patients with pulmonary exacerbations, and patients were randomized into 2 groups, control group with standard physiotherapy and those added with Simeox, and very significant improvement of maximum expiratory flow at 25% observed only in patients treated with Simeox encouraged us to continue with the study. Also opinion of patients and their big interest and demand to work with the experience with that equipment to get more experience also was a factor that we decided to continue. There is a graph of our exacerbation study, as you see on the graph, a maximum expiratory flow at 25%. Significantly increasing. A current study, which I'm going now to present for the first time, it's just finished, homecare crossover randomized control study. Everybody here knows very well that optimal chest physiotherapy at home is a key component of cystic fibrosis care. And the aim of our randomized controlled trial was to evaluate in children with clinically stable disease, this time clinically stable, the effect of a new airway clearance technology added to optimal standard care on lung function. Study design, prospective open label randomized crossover study run in our center between September 2019 to February 2021. As you see, it's a very new study. Patients were stable, age 8 to 18. Of course, we got bioethics approval for the study. Inclusion criteria, along with standard criteria like confirmed diagnosis and consent, it was stable clinical condition. So the patient had to be without pulmonary exacerbation 4 weeks prior to enrollment data, ability to perform lung function test, and of course, willingness to cooperate and learn new technique of drainage. Exclusion criteria, there were different pulmonary complications like hemoptysis, pneumothorax, recent chest injury or surgery, other contraindication to chest physiotherapy, history of transplantation, heart disease, or any other illness or clinical condition that, in opinion of the investigator, could confound the results. And now our interventions, we had 40 patients randomized 1-to-1 into 2 equal groups, each of 20 patients. We had 3 outpatient visits, 1 month apart for each patient. In Group R started first physiotherapy with Simeox after a training on the first visit. The second visit was after 1 month, and then at this visit, the device was returned and the patient started the previous chest physiotherapy. On the first visit, after 1 month, they were, assessment after a month without device. It was opposite in Group B, period of using Simeox and performing conventional physiotherapy were converted. Intervention. Chest physiotherapy was performed 3 times a day with device parameters individually adjusted for each patient, and during the period of use of Simeox, autogenic drainage for 20 minutes with Simeox session twice a day, PEP therapy for 20 minutes once a day, and physical activity. Once with the group without Simeox, autogenic drainage for 20 minutes, PEP therapy for 20 minutes, and usual physical activity. There is to show better. We see, well, first visit when patients are assigned and randomized to Group A or Group B. There is, after 1 month, assessment after first month, second month, and assessment after second month. I'm reminding therapy groups, we have conventional and Simeox group. What did we assess? Clinical data, pancreatic insufficiency, sinus, liver, so multi-organ disease was properly clinically assessed. Questionnaire known to most of people working in CF Word, cystic fibrosis questionnaire revised, treatment satisfaction questionnaire, and of course we followed all the adverse events and if any serious adverse events. Assessments, mainly lung function test. We have very comfortable situation in our center. We have quite a lot of space and own lung function lab designated for cystic fibrosis patients, so they don't need to go to central place, queue. Everything is within infection control rules. So we performed impulse oscillometry, spirometry, multiple breath nitrogen washout, and body plethysmography. A primary endpoint, it was change in total airway resistance at 1 month from baseline for these 40 patients. Secondary endpoints were other oscillometric parameters, LCI index, lung function, CFQR, and safety tolerability, which were assessed. Statistical analysis, treatment effect were compared, each group was compared to baseline, but it was also comparison between both groups. And there is baseline data of results. So you see we well, in the middle of this range of 8-18. All patients have really classical, you could say, cystic fibrosis, because most of them, over 90%, is pancreatic insufficient. Relatively moderate lung function disease, but all the quite varied in between them, and 20% of them had chronic Pseudomonas aeruginosa. Our primary endpoint on oscillometry, we didn't find any significant change after 1 month. On secondary endpoint, however, on maximal expiratory flow at 75% Z-score, we found significantly improved in the group in Simeox versus conventional group, as you see on the graph, but there were no significant changes in other spirometry parameters. Secondary endpoints, LCI Z-score did not change in Simeox group, but worsened in conventional group, which you could see also on this graph. No significant change in any other oscillometry parameter for both groups from baseline, so there were no difference between the groups. And also no significant change in body plethysmography parameters for both groups from baseline, and also no difference between the groups. Also among secondary endpoints, very interesting results on cystic fibrosis questionnaire revised in physical functioning, because we found significant improvement in Simeox group versus conventional group, but there were no significant change in respiratory score for both groups. From safety and tolerability, very important part of any study, only one mild adverse event, mild hemoptysis not related to device, which was solved. No side effects occurred during the study, no pulmonary exacerbation. 95% of patients didn't feel any pain or discomfort. 78% didn't feel any fatigue during drainage session with Simeox. All patients handle Simeox easily or very easily and use it at home. 78 like Simeox using at home. 73 preferred Simeox to conventional chest physiotherapy, and 95% would recommend Simeox to other patients. And coming to a conclusion, certain pulmonary function parameters improve significantly in cystic fibrosis patients using Simeox in home rehabilitation. The device may improve the drainage of the central and peripheral airways. It is safe, well-tolerated method of chest physiotherapy and can be considered an option in chronic treatment of cystic fibrosis. And I must say that actually it's already is an option in our center. It's a standard treatment we offer to patients, and quite a few of them already working with this equipment. That's why we decided to undertake study. First study was with exacerbations, and our second very new study, which is today, is the first presentation of results of stable patient study, also giving very, very good results. Thanks to that, we not only have subjective opinion of patients who are happy with the device and working on it, but also more objective assessment of this very good new therapeutic option and kind of new airway clearance device we need so much for cystic fibrosis patients. Thank you very much.
So do I start right away? This is Dorit Fabricius speaking. I would like to say some introduction or introductory words before the session starts, before the presentation starts. Is that all right? Does everybody hear me? Because the microphone. Okay, great. Great. So I should start right away, right? Okay. So dear colleagues, dear participants of this conference, welcome to our presentation of the study we have performed at Ulm University Hospital in Germany over the last year. In the study, we have investigated certain effects of Simeox therapy that so far had not been addressed, namely diaphragm mobility and mucus viscosity. My name is Dorit Fabricius, and I've been caring for patients with cystic fibrosis in our specialized OPD for more than 6 years. And during my work, I've learned not only how valuable the contribution of our physiotherapists is, but also picked up their desire to actually contribute to CF research. We all got to know Simeox on the German CF conference 3 years ago and wanted to better understand the effects of this new device. This led us to the design of the study, to which Hanna Schmidt, who will present our results today, has significantly contributed, particularly with her analysis of the mucus in the lab, but also by performing many of the diaphragm ultrasounds and by summarizing the data. Hanna, I hand you the word.
So thank you for this introduction. So the study I would like to present today was intended to investigate if and how Simeox therapy as a novel tool for mucus mobilization will affect CF patients. We addressed 3 main hypotheses in the study. So first, we hypothesized that mucus mobilization with Simeox can improve lung function. This was assessed with conventional spirometry. Next, we assumed that mucus mobilization with Simeox can improve diaphragm mobility, which was investigated in ultrasound-based analysis. And last, we expected Simeox to impact mucus property, and therefore we measured sputum viscosity and DNA concentrations in spontaneous sputum samples. We included 21 adult patients during a stable phase of lung disease. They were recruited when they were seen in our department for regular checkup visits. After obtaining consent from the participants, they started a first study session with an ultrasound of the diaphragm. This was followed by spirometry, and they were asked to provide us with a sputum sample if possible. Afterwards, they had the actual Simeox therapy, the intervention together with a physiotherapist. And after the intervention, they underwent the same examinations again in the same order. So first ultrasound of the diaphragm, followed by spirometry, and we collected a second sputum sample. We considered that patients may need some time to get used to the novel device and may not be able to use it properly right from the beginning. So all of the participants joined in a second therapy session with exactly the same workflow. And additionally, at the end, they completed a questionnaire reflecting their own experiences with the therapy. Now I would like to go through our main points and show you the respective data. And we start with the effect of Simeox on lung function. Patients performed spirometry before and after the intervention, and then we analyzed FVC, FEV1 at a maximum expiratory flow at 25, 50, and 75%. And when we look here at the data and compare the results of all participants measured before and after the intervention, there was no change in those parameters. So we found no short-term effects of Simeox on lung function. Then we go on with the second point, the effect of Simeox on diaphragm mobility. Here I first want to briefly introduce ultrasound-based assessment of diaphragm mobility to you. It's a method that allows direct functional assessment of the diaphragm. It is originally known from intensive care medicine, where it's used to examine diaphragm dysfunction in intubated and critical ill patients. However, recently it had also been used experimentally in COPD patients. And there it could be demonstrated that diaphragm mobility correlates with disease severity, and also that it can be improved by physiotherapy techniques. And therefore we were interested if Simeox therapy would also affect diaphragm mobility in our study participants, as this has not been investigated in CF patients so far. For the measurements, patients were placed in a lying position with slight upper body elevation, and measurements were done when they were relaxed and breathing at rest. And we then imaged the diaphragm in the right anterior axillary line. You see this here in the B mode image, and there the diaphragm appears as an echogenic structure just behind the liver. For functional assessment, we used M mode measurements, which reflect basically the diaphragm movements during breathing. Then we calculated for each breath 3 parameters. You see here first the maximum amplitude of diaphragm excursion and also the slopes of the amplitude increase during inspiration and during expiration. When we now look at the results of all participants and we again compare the values measured before the intervention and afterwards, and we look at the first graph, we see that there's a slight but significant increase of the maximum diaphragm excursion after Simeox therapy. There was no change for the slope during inspiration and expiration, but to sum up, this shows that Simeox therapy slightly improved diaphragm mobility. So our last point addresses mucus properties, and for oscillatory devices such as Simeox, it's generally assumed that they have a kind of mucus liquefying effect and thereby facilitate sputum expectoration. This has been demonstrated in vitro studies. However, in vivo, this could not be clearly confirmed. In our study, we used a microscopy-based assay to assess mucus viscosity. We used FREB, fluorescence recovery after photobleaching. I will not go into methodic details here, but for now you need to know that a half-time of recovery normalized to the half-time of sodium chloride solution. This is what's shown is here on the graph, correlates with mucus viscosity. And when we compare the viscosity values measured in the sputum samples collected before the intervention and collected afterwards, we see that there is a marked increase in mucus viscosity after Simeox therapy. This may appear surprising, as we heard that oscillatory devices are considered to liquefy mucus to reduce its viscosity. However, in our study, we assessed two separate mucus samples, so we cannot evaluate if there's direct physical impact on one and the same sputum sample, but we see clearly that the sputum portion we collected after the therapy has different properties and higher viscosity. As a second parameter, we measure DNA concentrations in the mucus samples. Mucus DNA is mainly derived from neutrophil granulocytes, and it is known that a number of neutrophils in mucus correlates with its viscosity, and in inflammatory lung diseases, therefore mucus viscosity also depends on the presence in a number of neutrophils. In our study population, when we look at the results, we see that in the sputum samples collected after therapy, there were higher DNA concentrations than in the sputum samples collected before therapy. And now we were interested if elevated DNA levels account for the increased viscosity in our sputum samples. Therefore, here in this graph, we plotted the difference of mucus viscosity after Simeox therapy against the difference of DNA levels of each respective sample pair. And here we see that for most of the samples, there's a strong near linear relationship which also reached statistical significance when we performed the Pearson correlation analysis. And taken together, this indicates that higher mucus DNA concentrations are likely to contribute to increased viscosity. We measured in the sputum samples collected after Simeox therapy, and we think that a reason for this finding might be that mucus is derived from different lung areas, probably also from areas with different levels of inflammation. So to summarize, in our studies, Simeox therapy was well tolerated by all participants and there were no adverse events, so it seems to be a safe method in stable CF patients. We found no short-term effects on lung function parameters. However, we found that diaphragm mobility was improved by Simeox therapy. The sputum we collected after Simeox therapy was more viscous, and this correlated with higher DNA concentrations, and we therefore assume that sputum after Simeox therapy is derived from different lung areas, probably from areas with different levels of inflammation, and this shows that Simeox therapy can help patients to expectorate high viscous sputum. So thank you very much for your attention.
Great. Thank you, Hanna, for this excellent presentation. And we are delighted to answer your questions after the session.
I have the pleasure to present now the main outcomes of the 3 European virtual roundtables that took place last May to discuss about best practices on Simeox therapy in CF care management. This is a summary of expert opinion on the effects of combined Simeox therapy with IV antibiotics, optimization of bronchial drainage during regular visits in the CF center, and personalized home care therapy. The first roundtable about reinforcement of IV therapy with Simeox resulted in several opinions. Simeox has fast benefits on lung function decline and sputum expectoration when Simeox is introduced from the start of IV therapy during daily chest physiotherapy protocol. This new technology produces rapid chest deflation in patients with lung hyperinflation, where combined with other therapies as CFTR modulators or other airway clearance therapy. Simeox is a safe and efficient alternative in patients with poor compliance or poor engagement by improving motivations for chest physiotherapy, and also in patients with bad general conditions or significant fatigue, as the device does not require extra effort, but only relaxed exhalation. The second roundtable on mucus mobilization during regular medical visits made the following statements. Simeox slows down lung function decline when it is regularly used during planned hospitalization or pulmonary rehabilitation. The technology is a safe and effective alternative, especially when standard chest physiotherapy is insufficient to mobilize mucus. Compared to standard chest physiotherapy, Simeox leads to a deeper bronchial drainage in the most inflammatory zone of lungs with less irritability and also lower cough intensity. The technology improves patients' cooperation for chest physiotherapy and gets optimal effects combined to other therapies. The third roundtable about personalized medicine in home rehabilitation made the following recommendations. Simeox education and training required only short time to be implemented successfully at home, and this quick adaptation contributes to high patient satisfaction. Simeox can be added easily to standard care, RCFTR modulators, airway clearance techniques, in order to optimize home care management, and especially in pandemic situations like the current COVID-19. Evaluation of short-term benefits of Simeox in the CF center allows to predict adherence at home, as it is strongly correlated. Compliance of home care Simeox can be easily checked regularly by phone call or remote tools. And efficacy of home care Simeox on lung function can be monitored over time in the CF center with sensitive methods like multiple breath washout tests, and especially in children. So the replays of the free European virtual roundtables are available on demand on our website, and you can make a request through the following link. Thank you for your attention. So in conclusion, I'd like to thank you warmly the speakers. Thank you very much, Professor Dorota Sands, for having presenting in details these important results from the first randomized controlled trial in children treated with optimal standard care at home. Thank you, Dr. Dorit Fabricius and Dr. Hanna Schmidt for the presentation of these very interesting pilot studies. And thanks for all the attendees. We hope that this symposium has provided you with relevant information on Simeox therapy. And now enjoy ECFS Congress and see you soon. Thank you very much.